Welcome, everyone. This is the Why Do You Vote Social Action Campaign. So, we are a part of Money Out Voters In, and it's a 501(c)(3) nonprofit. And we are focusing on 7 nonpartisan issues that more than 70% of Americans agree on. And today we're going to be speaking about healthcare. And I'm going to also now share in the chat. I hope everybody, you don't have to share your information here, but if you'd like to stay connected with people, and the resources will be here. So please feel free to add any resources, add your information. And I like to just, since the idea of these Tuesday chats is to connect, empower, and engage. And first, we're going to hear from our guest speakers. We have Louise McCarthy and we have Andre Stackhouse. And I thought, let's start with Andre, who is with Whole Washington, and learn more about what you are doing. And then later we'll have an opportunity to have lots of Q&A. So have a nice conversation here. So welcome, Andre.
Well, hello everyone, and thank you so much for inviting me today. My name is Andre Stackhouse. I'm from Seattle, Washington, and I'm the executive director of a 501(c)(4) nonprofit called Whole Washington, which has been around since about 2018, and is primarily known for being a universal healthcare advocacy organization that has run several statewide ballot initiatives to try to put a universal single payer style healthcare system on the ballot statewide in Washington. We also run this as legislation. So our commitment to the initiative is really, it's not highly ideological. We are trying to pass universal healthcare, as I say, by bill or by ballot. Um, but we deeply believe in the democratic process, and feel very fortunate to live in a state like Washington, where when our legislature fails to be responsive to the needs of its people, that the people have this other avenue in which they can directly legislate the kind of state that they want to be living in. So excited to talk about it a little bit more with you all today, and to hear everything y'all are working on as well.
Okay, thank you, Andre. And now we will welcome Louise McCarthy, who runs the Community Clinic Association of LA County, which is a huge county, kind of like many states.
Yeah, absolutely. I think, especially when we go back east and are advocating in DC, we have to remind folks that, Los Angeles is a county of 88 cities plus unincorporated areas. We make up about a third of the state of California. And yeah, as our own state, we would be one of the large ones. But as mentioned, I run the Community Clinic Association of LA County. We're the coalition of all of the nonprofit community clinics and community health centers in the county. So those are all folks that you might know as the free clinics, the community health centers, that see everyone regardless of ability to pay, the Planned Parenthoods. That's our coalition. And we were founded 30 years ago, specifically because all of these individual nonprofits needed to have a common voice, and to advocate at the county, the state, and the federal level for access to comprehensive quality care for the people that are under-resourced in our communities. So where we're at today is that countywide community health centers serve 1.97 million Angelenos. That's 1 in 5 LA County residents is served by a community health center. 1 in 3 of the residents who are on Medi-Cal, which is our Medicaid program, are served by a community health center as well. So just as we look at community health centers and just the sheer volume of what they're doing on the ground, it's just really critical to point to the fact that we have a large number of remaining uninsured, despite all of the expansions that California has done. We've expanded care under Medicaid, our Medi-Cal expansions, not just for folks that can get a federal funding because they're documented, but the state is putting state-only funds in for those who can't get the federal match, who are undocumented. So we've made massive expansions. So now, when we look at the community health centers, 72% of the patients that go in to see them, of that 1.97 million, are low income. 92% are either uninsured or on public insurance, the majority of that being Medi-Cal, and over 87,000 are experiencing homelessness. So as we look at the issues that we're advocating for at the county, the state, and the federal level, Medicaid is a huge, huge piece of that. Our Medi-Cal program, we do have a ballot initiative, Proposition 35, and we can put some information in the chat about that, which we are doing in coalition with a wide array of safety net partners, private physicians, hospitals, dentists. We actually started this out working with labor as well, basically saying we've got to find a way to fund our healthcare system. And I will say to Andre, yes, we've long been supporters of the big reform, but as long as we're on this road, we've been expanding benefits in our state program. We've been expanding eligibility, but we haven't changed the way it's financed. And so unfortunately, we've got hospitals that are at the brink of closure. We've got patients waiting for specialty care visits. No providers won't accept the rates that are paid by the state. And we really need to, we've got, 10% of people in LA say they have difficulty finding primary care. So we need to find a way to finance the system as we wait for future reforms, the big capital R reforms to really overhaul the system. We need to make sure that it works. So Medicaid is our big issue, and workforce as well. We are in a major healthcare workforce crisis. Nurses, providers, billers, coders, front desk, you name it. Everyone is competing for healthcare workers right now. So those are our big issues. I'm happy to get into more conversation about all of that, and I can put some links in the chat to some infographics and some reports that we've done that will tell you a little bit more about it.
Thank you, Louise. I'm looking, you guys are doing so much and helping so many people, and the numbers are kind of staggering when you think about it. So before we go to open up and have our conversation, I just want to share briefly again. So we are hosting the Spark the Vote social media and film challenge, and we want all of our submissions by Democracy Day, September 15th. And we're asking people to make short social media posts about why they vote. And we'd love to get brief personal stories about healthcare and why people vote for healthcare, and how, either lack of healthcare or gaps in healthcare, how it's affecting people, because it's really powerful to get these stories and bring these to people online. And we actually have $50,000 in award money for best videos. And I'm just going to show you a 1-minute reel.
I vote for women's choice because we need autonomy over our own bodies. Why do you vote?
I vote because democracy is an important part of the American spirit. Why do you vote?
I vote because the people who came before me made so many sacrifices to make my vote count. And that's why I vote. Why do you vote?
I vote because I want kids to be safe at school. Why do you vote?
I vote because of marriage equality. Why do you vote?
For our environment, to hear our planet, to hear your rights, to hear for everything. So that's the reason I vote. Why do you vote?
I vote because I believe in universal healthcare for all. Why do you vote?
I vote because I care about marriage equality and people exercising their rights. Why do you vote?
I vote because action is the antidote to despair. Why do you vote?
VOTEE.
Okay, so those are simple ones, but we'd love brief personal stories about healthcare and get people talking about voting for healthcare. I think, all young people are on social media. If we can reach them with these messages, we have $50,000 in award money. So we'll have like 10 prizes of $50,000. So please encourage people to make videos about voting for healthcare. And I will share that link here and in our spreadsheet. But now I'd love to open up does anybody want to share why they've joined the call, how healthcare is affecting them, or share, ask questions to our wonderful guest speakers and what's going on on the ground in Washington, here in LA County?
I have a question for Andre. Would the single payer system also include mental health care?
Yes, it would. So the intention of the design, and some of this does need to be borne out through implementation, and the bill that we have does have a transition plan, et cetera. But it is intended to be both universal in its coverage, the who's covered, as well as the what's covered. And we have a lot of analysis that basically shows that kind of splintering people off into private payers really just makes healthcare more expensive. And so we kind of recommend a very, very integrated, comprehensive public coverage plan.
Thank you.
Yeah, that's one of the things we talked about on our first call a lot, how mental health, really falls through the cracks. And there's not enough providers right now. It's so insanely expensive. It's prohibitive. The waiting lists are so long. I know, Louise, that must be a huge problem, especially with when we're seeing people who are, having to live on this, they're unhoused. That mental stress alone must be just staggering. So it'd be great to hear, like, what are you seeing, like, what's working, how to best help people, what solutions I know LA has been trying a lot of things. I know Washington State's been trying a lot of things. It would be great to hear.
Yeah, absolutely. And we work in the behavioral health space broadly, which includes substance use disorders, medication-assisted treatment, and kind of holistic support, as well as mental health. And as we look at it here in LA County, certainly there's this workforce issue. And so one of the things that we've been doing is trying to make sure that everyone's able to work to the top of their scope of licensure. In California, we have marriage and family therapists. I don't know that they exist in every state across the nation. We want to make sure that they're billable providers in our Medi-Cal program, that they're recognized and able to serve folks, as well as our licensed clinical social workers, our psychologists, our psychiatrists, and just making sure that they're willing and able to take the payments for our healthcare programs, because you can have coverage, but if you don't pay fair rates to the providers, they're not willing to accept it. And it's really tough. One of the things we're doing specifically is focusing on prenatal mental health. And so we have an initiative called the Los Angeles Maternal Mental Health Access. And it's, if we look at LA County, 1 in 5 women experience perinatal depression. And mental health conditions are the leading cause of pregnancy-related deaths up to a year postpartum among both white and Hispanic women. That's a national number. So what we're looking at is really this question of, let's make sure that everyone gets screened, right? When you come in for anything you come in for, we want to make sure that you get screened for anxiety and depression, and get referred to counselors or psychiatrists that can provide support. And, working to make sure that the nonprofit community providers who are, they're scrappy, they're trying to make it work, trying to make it happen on a nonprofit budget, but making sure that they have the resources, connecting them with folks at actually the University of Washington. So Andre, I guess we're in partnership between our states already. We're working with them to make sure that the health center providers have support to be able to identify and treat perinatal mood and anxiety disorders, reduce the risk of suicide, and really integrating mental health into the primary care setting. So it's making sure that, we reduce stigma. So if someone goes in for a visit with a primary care provider, they're doing the screening, you're filling out a 9, 7, however many questionnaire. And if anything's flagged, we want the behavioral health provider to walk into the primary care room. So there's no additional step. There's no referral to another appointment that someone might not make. I mean, you've got life is happening for folks. And that's for folks, for everybody. And so think about it if it's someone who had to figure out where to stow their stuff if they're camping on the streets, and going in for care really is a challenge for them. We want to make sure that we bring everything holistically to them. And so in order to do that, we need to make sure that our state actually pays for those services. Unfortunately, in California, it's kind of funky. Our state will not pay for a medical and mental health visit on the same day. They will only pay for one or the other. And in part, I think they do it because they know the health centers are going to do it anyway. So they're getting it for free. They're getting it for free. We've run bills, we've run, I don't know how many, 5 bills now in the state legislature to force the state to actually pay for behavioral health on the same day as a medical primary care visit. And it gets vetoed every time.
But you want efficiency. It's like efficiency.
Yes, and it provides care.
Efficient, not
Yep.
always like.
Yep, but I think they're getting a free
efficiency.
they're getting a freebie because a lot of health centers just say, you know what, I'm going to write a grant to a foundation. I'm going to, skimp on some other costs because I know that this person is not going to come back if we don't do this visit. So they're just eating it.
Wow, that is shocking. I know we were also talking on our pre-call about, last week was our call about women's bodily autonomy, and how you were saying how LA County has been overburdened because of what's happening in other states. So we are all interconnected, and I'd love if you could share a little bit about what we talked about yesterday.
Yeah, absolutely. As we look at the policies that are happening in other states, both near to our borders and far. LA has already been a destination for care for people who cannot access it in their states, which is just terribly unfortunate. And so that increases. We're also a destination for protesters. People ship their protesters out from other states across the nation to come and circle our Planned Parenthoods and berate patients and providers alike. So it's really been a challenge just of access and making sure that people have access to care as well as safe access. And California has, really worked to make sure that there are resources available for Californians and anyone that needs access. We mandate in California any healthcare coverage has to be comprehensive. It has to cover abortion. Whatever your employer-sponsored health insurance, you name it, California has that mandate. There's been funds allocated from the state budget for reproductive health care, including abortions. And actually, the proposition that I put in the chat, Prop 35, also includes funding for reproductive health. So trying to make sure that we're, propping up this safety net so that people who are of reproductive age or capacity are able to get access to the resources they need. Unfortunately, still today, the Commonwealth Fund put out a 50-state report a couple weeks ago looking at the health status of folks in all 50 states. California did really good on some things, like morbidity related to births. We're on the top. However, we're on the bottom for women of childbearing age having a usual source of care, which is unfortunate. So as we think about that, it's that kind of access that helps prevent the need to end up down the line for the needing an abortion. If we can get to folks earlier, it's easier on them, it's less costly for the system, but we want to make sure that at any point in which they need access, they're able to get it.
And Andre, you were so brief in your opening. I'd love to learn more. I was hoping you'd share more about what you guys are doing, how you're working towards progress, what's going on in Washington, and any other insights. We'd love to hear about your organization.
Well, it's been a long journey. Whole Washington, as I said, was founded in 2018. And I've been there for, I guess, about 4 years or so. But, there was initially a lot of emphasis on the ballot initiative, and in Washington State, we need about 500,000 signatures to make the ballot. It's a big effort, and it probably requires a lot of money, a little bit more than we've raised. And so, while we continue to build for an initiative, one of the things that we've been doing is a town hall series. So we did a town hall series where we tried to get all across Washington, including east of the Cascades, and out to the Olympic Peninsula, and to hold these town halls. And we did some in collaboration with partners, others were more focused on ourselves, but we really just wanted to provide space because what you find when you gather signatures is that people are generally receptive to universal health care, and they'll say, oh, sure, I support that. They'll sign it. But kind of beyond that small, simple action, people are very sensitive to the details. They want to support it, but they can be kind of easily spooked by industry talking points. They can be worried about losing their current healthcare coverage. And so the Town Hall series really provided us a way to bring out voices in Washington who are working on this stuff, people who are suffering and have stories to tell. And one of the most interesting things about it was that, while we kind of have thought of Seattle as this sort of ideological bastion for what we're doing, it's very liberal, people are receptive to it. Our attendance in Seattle, and, again, very densely populated, kind of felt like a lot of people maybe had better things to be doing. Whereas when we went out to some of the more isolated communities in Washington, we could pack a room with 30 or 40 people because they're the ones who are most acutely suffering. So, we believe, there are about actually 500,000 uninsured people in Washington. So we often kind of make the case that just the uninsured could kind of sign an initiative to put health insurance for themselves on the ballot. So the support is out there, but it's difficult to acquire. On the other side of things, on the legislative path, we've introduced our legislation over 6 sessions, and it has not ever been given a committee hearing. And so for us, it's a very big obstacle where it doesn't feel like there's a lot that we can do about that. And one thing that happened a few years ago was the legislature, I think in response to the sort of visible unhappiness with the process, created a commission that has been a little bit more mixed because the commission has provided a sort of formal platform for a lot of the hard questions about healthcare reform to be aired. And one of the best things about it has been that we got to present to this commission 3 times to really get into the nuts and bolts of how our proposal works. And by the way, if anyone wants to view those presentations, wholewashington.org/commission has been where we put those videos and the slides from the presentations that we've given. And it has been one of the best opportunities for me to really get into the details and explain what it is that we propose. And the commission actually gave us a report back on our legislation. And while there was a lot of expectation that it would be very negative, and ultimately it did say, we're not ready to recommend this to the legislature at this time, it did pull out a number of areas of alignment that we are working to move forward on. So while we will continue to maintain our kind of signature single-payer universal legislation, we're actually currently working on a Medicaid deprivatization bill that would maybe even go a step further. So deprivatize Medicaid and then combine it with, there's basically 2 major public insurance plans that cover the vast majority of public sector employees in Washington. So one covers public school staff and the other one just more government employees. But the thinking is, between the labor unions and all of the grassroots orgs that we work with, and again, like we say, we do encounter certain forms of skepticism and hesitation, but the commission and this big coalition seems to all agree that we are ready to deprivatize Medicaid and combine our public sector plans and effectively create that single payer and create that public plan that can begin the process of enrolling people. So, whether it happens through one bill or multiple bills or administrative action, we know that a huge amount of this is going to happen over time and through voluntary enrollment. It's not going even if we passed the bill and it was written exactly the way I wanted it tomorrow, it would still take multiple years to really achieve it and make it a reality. So, you know, I think some of the best progress in the last couple of years has been to take a more coalitional approach to incorporate some of the feedback that we were getting out there. And it's a political change is a complicated thing, and it's always tempting to say, well, we could just put this on the ballot and get this done, or if the legislature would just pass the bill. But the reality is all of these are avenues for us to build public awareness and public support. And it's not even clear to me, when I spend all day in this work, where is the next major progress going to happen, and so I always encourage people to keep a very open mind and to recognize the different avenues of change, and also to recognize a process for what it is. The legislature has kind of explained the way that they are going to work on this, and we can call them out on it all we want. We can be very upset with them, but ultimately the legislature is going to work the way that it works. And it's different than the initiative, which is why we have the initiative. But I think that despite the barriers, there is still a lot of room for optimism.
And I'm going to jump in on that, actually, Andre. I'm really interested. I think that just that marriage that you're dealing with between a legislature, which is living in a one budget year at a time, their time horizon is it's really hard to do long-term planning with legislatures, because they're just like, we got to pass a budget, zero-sum game, here's how we go. Whereas when you take something to the electorate, you can have a longer-term plan. And that's just kind of moving the time horizon, which I just think is really important, because healthcare, we can't turn a cost curve on a dime. We can't turn everything around on a dime. Healthcare takes a while. The other thing I think was interesting about your comment on deprivatizing Medicaid. In California, we actually have that in 17 different counties in California. We've got what's basically the public option, which they're nonprofit, publicly governed health plans. We've got one here in LA County, LA Care Health Plan, which has 3 million lives that it takes care of. Networks of providers, it operates, and it competes against the for-profit plans. And so they compete against each other on quality metrics in order to be able to show the state, okay, who's serving the Medicaid population better? And whoever does, the state gives them more enrollees if the enrollees don't choose one plan or another. But it's been a really successful model. We didn't get the public option through the Affordable Care Act after all, but we've had it here for almost 30 years because of these locally governed, publicly governed nonprofits that are akin to the public option. I think it's great that you're looking at that, because it's an effective model and you save costs.
Yeah, and I just wanted to add one other thing that did come up a little bit going back a ways, but I also, we often face certain skepticism about taking action at the state level because of all of the challenges that come with coordinating federal plans like Medicare and federal regulations like ERISA. And these are real challenges that we do have solutions that we think are viable. But one thing that I think is worth mentioning is, I use the example of abortion and reproductive care because it's most related to healthcare. But this is one of those things that was, established in Washington before Roe versus Wade and remains, firmly legal after the repeal of Roe versus Wade. And I think that this, as a metaphor, really should show people, we have a similar situation where many people from Montana and Idaho come to Washington to receive these services. And so despite, the challenges that can come from getting out ahead of the federal government or having a more universal, less corporatized healthcare system, I think that we just need to recognize that ultimately, it is our state's responsibility every bit as much as our federal government's responsibility. And this actually, even when you have the same protection at federal level, you have more protection when it is reinforced at every level of government, and including local, by the way. And one of our models for navigating some of this actually comes from San Francisco, the program called Healthy San Francisco, which is interesting because it's actually both kind of San Francisco being a unified local county government. So we've looked at stuff that can be done at a more local level. And at times, we think San Francisco is a good comparison for Seattle. At other times, we say, hey, maybe King County, which is effectively the greater Seattle area, a little closer in population to San Francisco. But again, a lot of potential there. And I think that if we were to get successful policy at, say, the King County level, it would become something of an inevitability at the state level. And again, this is also how we pass things on to the federal government, whether it was marriage equality or cannabis legalization. These are all things where we were able to establish this here in Washington and have seen, the spread of that in other states and in some cases federally. So even when we're talking, well, we need Medicare for all, well, we need these federal waivers, establishing it here as law in Washington is actually probably the most influential way to make that happen.
And yeah, it's the way to push. If the federal government, if state government moves slow, the federal government's even slower, And so we really, I can't agree with you more, Andre, that sometimes we just need to do it and then get folks to follow.
Yeah, one thing I love about this conversation is like talking and sharing with people how the legislative sausage making happens. So I originally got into the healthcare issue because I made 2 films on the pharmaceutical industry. And then I also made a film about money in politics. And it's like, you wonder, are these bills getting stopped because of the money in politics? Big pharma, big insurance, these are some of the top lobbyists. They spend some of the most money to, stop change, sometimes just stopping change, killing a bill. And our sponsor Money Out Voters In, that's the key issue they've been working on since they were founded, to overturn Citizens United, because we know how deeply these lobbyists, just killing a bill, until next year, it's like slowing it down. And it's interesting to see that there's been some progress in getting competitive drug prices. Just competitive drug prices, how much that can affect an individual for having affordable, like the medicines they need to survive. I know somebody who moved to New Zealand. She was, half American, half New Zealand, but she's like, I can't afford to live there because my drug is not covered. Like, it's shocking what this means to real people.
And that's why I think, looking at the federal level, the Medicare finally negotiating drug prices is huge. You've had this purchasing power all along, yet I have family in Minnesota who would go to Canada to get medication because it's just cheaper. Here in LA, I know people that go to Mexico because it's just cheaper. And so Medicare finally negotiated drug prices. California's been working on this California RX program, which it's still in development phases. But if you have that kind of purchasing power, why not flex? Why not flex when you've got, because big pharma's not going to drop prices just out of the kindness of their hearts. That's not how they roll.
And then with pharma, there's only the US and New Zealand even allow drug ads on TV, and we know how expensive advertising is. And then it's always like, oh, the marketing costs. It's like, how about those advertising costs going into and like, why should you be asking your doctor about some drug that you've seen on TV? Like,
I want to
be the expert.
I want to get a shout out for so National Nurses United is a fantastic, the largest nurses union and one of the best when it comes to advocating for universal health care. They're running a wonderful campaign called Patients Over Profits, which effectively is a clean money pledge campaign. And it allows no more than $200, which I think is good because it just makes it so that small donations and stuff don't have to be a big deal. But effectively, any signee of the Patients Over Profits pledge, is swearing to not take money from the sort of medical industrial complex. And you can sign it as a candidate or an elected official at any level of office. And so this provides a really good way to treat this as an electoral issue. You can, ambush somebody at a town hall and just the pledge is like about a paragraph long, so you can usually read the whole thing and just say, are you ready to take this? And they've got a lot of signees, so I think that's a great way of addressing sort of the money aspect, even if we can't overturn Citizens United just yet. But the other thing I wanted to say, about the economies of scale, price negotiation. Yes, Medicare can do that. A state level implementation like what we're doing at Whole Washington could also do those negotiations. But I want to emphasize again, when we're taking things to this state level, I think one state breaking through will be very hard. We've seen that the industry will resist these things. They spent a lot of money to defeat an initiative in Colorado a few years back. But at the same time, as multiple states begin to implement universal health care, it will be very mutually beneficial. So Oregon actually passed a constitutional amendment to add healthcare to the sort of rights articulated in their state constitution, which is a mixed bag because it's not actually an implementation. So kind of they're saying, okay, we think everyone should have the right to this, but we haven't really figured out how. And they currently have a task force that is struggling to answer all the questions and make it a reality. At the same time, I think it's very important that we support Oregon. It's right between Washington and California. And the progress that they make, that is going to have knock-on effects in our efforts in Washington and California. And so even just questions of like, okay, so who's eligible? Is an out-of-state worker who lives in a different state but works in this state, are they eligible, right? And if we coordinate with Oregon, we can be like, okay, so do we split that? Is it covered by one state versus the other? So these are challenges, and as states develop these, they should be coordinating in time. What I think is possible and what I would love to see is something of like a left coast healthcare system, right? I think Washington, Oregon, and California, I don't think that there are really legal reasons why they couldn't do this. And if they were to combine, I mean, that is a significant economy of scale, one that you could imagine being expanded to the rest of the United States. And so at the end of the day, there is always going to be a state-federal partnership on healthcare. But the more we can coordinate, the more we can kind of mutually support the efforts, especially in states, close to our own. I think the sooner we will be benefiting from a universal healthcare system.
That's a great idea. I love that. Actually, when we were passing the Overturned Citizens United Act here in California, Movi was the sponsor of Prop 59. We were working with WAMEND in Washington, who also passed it. And one of our great partners is Fix Democracy First. So I love that these calls just bring people together that aren't usually talking and how we can, talk about working together across issues intersectionally. I'd also love to open it up to questions. I mean, you guys are doing so much amazing stuff, and I love the educational aspect of what you're doing, Andre. And I'd love to make sure we're sharing, all of the places to watch the town halls. I really want to check those out. But I'd love to, does anybody have any questions?
Well, I guess just a comment, Louise mentioned dentistry as well. And I wonder if that's also included and care for the elderly,
Eye care,
dementia, eye care. Yes, like all the things that don't seem to normally be included that people need. It's part of your health.
Well, luckily here for, I can't speak to the single payer side of things, but as far as Medicaid goes, we've been able to maintain dental benefits. And unfortunately, we're dealing with a little bit of deja vu here. In 2010, with big budget deficits coming at us, our state wanted to eliminate adult dental in our Medicaid program in Medi-Cal. And we sued. People sued. Because you know what? Once you give someone a benefit, it's really hard to take it away. And it's really unfortunate that dental has, our mouths are not treated as being part of our bodies. Similar, I mean, we do this piecemeal medicine. It's like, okay, you folks deal with the brain, you guys deal with the, emotions, you guys deal with the teeth. And Medicare has had historically, things have improved, but with the dental benefits for elderly, it's been really problematic. So as we look at now in California, in particular, thinking about so yes to the oral health side of things, and that's why we were important to bring the dentists into our coalition on the Prop 35 initiative, because we want to, I mean, dental is one of the biggest access issues for our Medicaid Medi-Cal program. But then on the senior side, what we're looking at in particular here in Southern California is we've got folks, we did this great Medicaid expansion for folks who don't have documentation. Well, they're not going to be eligible for Medicare. Our Medicaid program is going to be the only thing that they have. We want to make sure that everyone who is eligible for Medicare gets on it and is able to get robust benefits. But there is a swath of society who just are not going to be eligible for those federal programs because of their documentation status. And so thinking about how do we help people to age justly in society, that's something that's really kind of it's some noise in the back that we can't ignore as we're having all of these conversations.
Absolutely. Yeah. My mother had Alzheimer's. That was extremely costly. The extra, even though she had Medicare and insurance, there's all sorts of extra costs that go with that sort of illness that aren't covered by anything really. So
exactly.
Yeah, if you don't have savings when you're older, and especially living in California or the left coast, the cost of living is so much higher than it is, in the middle of America, and all of these healthcare systems don't take into account the fact that like the cost of living is so different in different parts of the country. And in like a larger city where all your other expenses are more, they average it out across the whole US when that doesn't really seem fair,
Mm-hmm.
Yeah, I don't know why they don't say, okay, well, if you're living in this city, we should change the threshold of income.
So this is a conversation I love, because the federal poverty level, it's every year we get the notice that here's the rankings for the federal poverty level. Well, if you live in Hawaii or Alaska, it's different. There is a modifier for those states. And so I don't hold out hope that at the federal level we'll get folks to do anything. And there's a whole lot of people in Congress that don't love California, if you can believe that. They don't love the best coast. Many of our and all the cool stuff that's happening up and down the coast. But having some sort of modifier on the federal poverty level is absolutely critical, because it's unsustainable to think that eligibility for a program would be the same in Arkansas as it is in Los Angeles, where the cost of living is so very different. The other thing that, absent any political will in Washington and DC to do anything about that, Los Angeles and other parts of the state, and I know other parts of, across the US are looking at basic income and doing tests with that on most recently looking at we're looking at a 2-year program for folks coming out of foster care. And getting them $1,000 a month basic income and making sure that it does not impact their eligibility for public programs, because you want to make sure that suddenly making that $1,000 doesn't push you into another bracket where suddenly you can't access the programs that were supporting you. But so far, only like we're 1 year into the program, it's having really amazing benefits to see. And so once we get up to an evaluation, I think it'll be really exciting to see where that goes.
For sure, because it seems absurd if you're supposed to make less than 22,000. I'm not sure how much the threshold is in California to receive Medicaid, I guess California's version of that. Then, I mean, nobody could live on that. And so it just doesn't make sense, but you're not making enough to pay for premium insurance. So there's people in the middle that fall into the gap.
And I'll just go ahead and throw out, I mean, I'm a big advocate for universal programs, whether we're talking about, income or healthcare or housing. But I think that that Medicaid gap that you refer to, I mean, it's famous. It maybe doesn't even need to be said, but there were a lot of claims made about the Affordable Care Act, right? One was, if you like your doctor, you can keep your doctor, which was people lose their coverage all the time, right? So it's not exactly a fault of the Affordable Care Act, but you can just see why the flaws in the design create this confusion and political resentment, right? Where it was like, I was on Medicaid, but I got kicked off just because I got a job, I got a raise or whatever, right? Or people who are outside of that threshold, they actually struggle to pay the most because they're not eligible for assistance, right? So they are maybe having premiums that they pay every month, but they still have really high deductibles. And then they see people on Medicaid and they go, oh, why do these people get good healthcare coverage when I'm a good working person? I can barely afford it, right? Universal programs, and it's kind of like Louise was saying earlier, hard to take away a benefit once somebody has it. And so that is a key aspect of the design of universal healthcare, is that we're all in this system, and cuts to it are cuts to all of us. And so, I think that it creates that sense of solidarity. It creates a sense of investment. And again, I think even when you can make something free at the point of use, it clarifies it so much, because people know they pay taxes. I pay taxes all the time, but when I went to the hospital, I got charged, right? Instead, okay, fine, I pay taxes. I don't like paying taxes, but when I went to the hospital, it was paid for, right? I think that is a clearer relationship between taxpayer and public service.
Especially when so many bankruptcies are because of medical debt. It's shocking.
The majority.
Over 60%. Yes. And that's really like one, and you're already sick, and then now you're going bankrupt. It's like being sick is bad enough. It's really sad. It's really heartless the way our system is created. Oh, I really appreciate this conversation. It's so wonderful hearing from you guys. It's like if we're all working together step by step, we can push for progress, but we have to keep connected. We have to keep talking about it. If we're not talking about it, everybody thinks, oh, it's fine. That's why we're trying to have this social media conversation and talk to people where they are outside of the big media, because the big media wants to have one conversation, but we can have another conversation online directly amongst each other. And that's kind of why we're doing this whole campaign and trying to get people to think about voting in regards for these issues and how they can be effective citizens, not just voters, learn more, educate, and then become more effective citizens and help create the future we all want. Does anybody else want to share anything or ask anything before we end the call?
I'll just say one more thing. Uh, this is this was a little bit more of a personal project, and the primary was not too long ago, but I did run for governor of Washington to put universal health care, as well as a bunch of other issues, including a housing guarantee, a universal income, and a bunch of things on the ballot statewide in Washington. And you know, there's a long way to go between kind of where my campaign ended and being elected governor. I don't know if that's something that is, will be something that I pursue that intensely. But one thing I explain when people ask, why would you put yourself through something like that, is to say that it doesn't exist unless it's on your ballot. And all of these things are very nice intellectual issues that we can kind of cut our teeth on and talk about. But I really appreciate this event and the framing of it and all of you being here today, just because I think it is so important that we remember that elections, uh, we're not really voting for somebody because they're a nice person and we like them. I think it's very, very critical that we have expectations, and that we almost see it in a certain kind of transactional way, which is I'm voting you in to give me something and to do something. So I really encourage on this and every other issue to be fearless about treating it as an electoral issue. It's not asking for too much. It's not being annoying. It is the point of the process.
And I appreciate, I'll say that, look at the rest of the ballot. We've got all these measures, all these propositions, focus, and people focus, solely on the top of the ballot and the individuals. But there's a lot at stake when we look at, we also here in Los Angeles have Measure A, which is going to bring a significant amount of funding in to support getting people out of homelessness. So we got to look at every piece of the ballot and make sure that we're voting with information and getting informed and able to make those choices.
Exactly. Like our whole campaign is to not talk about candidates, but to talk about the issues and that your vote can affect the outcome. Your vote is important. It is your voice and empowering people, and to look especially down ballot because it's the local stuff that ends up affecting you so immediately. So I really thank you guys for taking the time and sharing all of your wonderful knowledge and insight. It has been a pleasure, and I hope you join us for more calls. If anybody else wants to say anything, we still have the floor, but I think I'll end the recording now.